Today, I will talk about contraception. We'll talk about effectiveness, mechanism of action, benefits, and risks. I will discuss the different types of contraception, from hormonal to IUDs to barrier methods, natural family planning, and postcoital, also known as emergency contraception. Insert table 24-1 on page 224 of Obstetrics and Gynecology used by the medical students. As you can see in this table, if a woman does not use any contraception, typically 85% will become pregnant in a year. The hormonal contraceptives vary from 0.05% to 8% pregnancy rates in a year, making them very effective. The IUDs vary from 0.2% to 0.8%, making them a more effective method of contraception. Barrier methods are much less effective, and in the table you can see that they are anywhere from 15 to 29% pregnancy rates if used for 1 year. Let me rephrase the barrier methods. Barrier methods have failure rates of from 15 to 29%. That is, that number of women will get pregnant using these methods in a year. Natural family planning is relatively effective, but takes a dedication on the patient's part to make it work. Postcoital contraception will result in 25% pregnancy rate. Of all the contraceptive methods, oral contraceptives are the most commonly used. This involves taking a pill on a daily basis for at least 21 days each month. There are two types: the combined estrogen and progesterone, which is the most common and referred to as the pill. And then the progesterone only pill, which is typically used in selective situations. Mechanism of action for the combined oral contraceptive relies on progesterone's effect on LH, which is suppressed, thus preventing ovulation. Progesterone also thickens cervical mucus, preventing penetration by the sperm. In addition, progesterone decreases tubal peristalsis and decreases transport of the ovum through the tube. Estrogen stabilizes the endometrium to help decrease breakthrough bleeding. It also suppresses FSH and inhibits follicular maturation. The progesterone-only pill acts as above to suppress ovulation and thicken cervical mucus. However, using it, ovulation still occurs in 40% of patients. This pill is useful in postpartum women who are lactating, since estrogen decreases the production of breast milk. One would not want to give a combination pill to a woman who is breastfeeding. It's also useful in any woman where estrogen is contraindicated, and we will discuss that momentarily. Benefits of the combined oral contraceptive are decreased menstrual flow and decreased in dysmenorrhea or painful menses. The menses become more predictable while on an oral contraceptive. There is less iron deficiency anemia because of the decrease in flow. It decreases rates of endometrial and ovarian cancer. There's also a decrease in benign breast disease, ovarian cysts, and pelvic infections. Risk of the combined oral contraceptives are primarily due to the estrogen component. All these risks are dose related. There is an increase in clotting factors because estrogen increases antithrombin 3, protein S, and some clotting factors. Venous thromboembolism is therefore increased. The relative risk and incidence I will show momentarily. In young women, the relative risk is 1, with a 4 to 5 per 100,000 incident. In pregnancy, this goes up to a relative risk of 12, meaning that in pregnancy, the risk of a venous thromboembolism is 12 times that of a young non-pregnant woman. This produces an incidence of 48 to 60 per 100,000. A low-dose oral contraceptive, that is one containing less than 50 micrograms of estrogen, has a relative risk of 3 to 4 with an incidence of 12 to 20. So while the incidence and relative risk are increased, they are certainly not as great as when a woman is pregnant. Additional risks include changes in lipid metabolism. However, these are confined to low-dose OCs with greater than 50 micrograms of ethinyl estradiol and greater than 100 micrograms of levonorgestrel. Low dose are those with less than 50 micrograms of ethinyl estradiol and less than 100 micrograms of levonorgestrel, which is one of the most potent progestogens used in oral contraceptives, do not affect lipids. Another concern is arterial thrombosis producing myocardial infarction or ischemic stroke. Studies show that when you control for high blood pressure, smoking, and higher dose OCs, there is no increase in either. So with the low dose OCs, that concern has been eliminated. Smoking, however, is a tremendous risk when using the combined oral contraceptives in a woman greater than 35 years old. The myocardial infarction risk goes from 10 per 100,000 for a woman over 35 who is not smoking or using oral contraceptives to 88 per 100,000 in a woman smoking who is over 35. And if you add in the oral contraceptives to a woman who smokes and is over 35, the rate jumps to 485 per 100,000. So smoking and being over 35 is a contraindication to taking the combined oral contraceptive. In this same woman who is over 35, a risk of ischemic stroke is 10 per 100,000. And then with smoking and oral contraceptives, this jumps to 25 per 100,000.